Hi everyone, welcome to the AWE 2026 hands-on segment on EUS guided radio frequency ablation. I have with me Dr. Ken Chang and Paul Cork and Jen, all from Hoag Hospital. We said this is a Hoag sandwich, or otherwise known as a hoagie. With me in the middle, Uzma Siddiqui from University of Chicago. And so we're hoping to demonstrate on our pork chop the technique of EUS guided RFA. And just briefly, I'll kind of go over the technique, and then these guys will give you a little bit of background on indications, whether we're talking about pancreatic cystic lesions or cancers. So right now you see this Taiwu, it's a 19 gauge needle, and it has an insulated inner sheath, and on the tip is where you get that ablation zone. There's 3 different sizes, 5, 7, 10, and then depending on the size of your lesion, you're going to choose the appropriate needle. So for a 5 millimeter needle, it'll be about a 7 millimeter ablation zone. For the 7 millimeter needle, 9 millimeter ablation zone, and then with the 10, a 14 millimeter ablation zone. But we could probably all agree that the upper limit of size is going to be 2 centimeters realistically to get a good ablation of a lesion. And so we have chilled saline coming through here, and then we're going to put our lesion, in this case it's about at 6 o'clock. This 19 gauge needle is a little bit more floppy than a standard FNA needle. So if your scope is in a straighter position, again, it makes it easier to enter the lesion, especially if lesions are in the panc body or tail. And then you'll see the needle come out, and we'll adjust it a little. And then we'll go in, and then we will start the ablation. So for this 7 millimeter needle, we're going to do 45 seconds of ablation. The 2 things you're going to control on the processor, or when you start the ablation, so the time, how long you're going to ablate for, and you see that kind of white, bubbling there to know that you have a good effect. And then the other thing that's being monitored is impedance. So if it gets really high, over 400, you're going to have to manually stop it, and I think it auto shuts off at around 800. But that's pretty much it. So I'll let you guys talk a little bit more about the indications and when you use it.
So I can start with neuroendocrine tumors. In our practice, we choose select patients with neuroendocrine tumors for ablation. That's in collaboration with surgeons as well. I've had good success with some insulinomas, so they're very benign behaving, can ablate them and cure the hypoglycemia. And then sometimes for some non-functional neuroendocrine tumors in patients who are maybe a little bit more anxious, or if the lesion has shown some growth over time and we want to ablate it before it reaches that sort of 2 centimeter threshold where we start to worry about it more. It's been very effective. And I'll pass it over to Ken.
I was going to ask one question. So if you're using it on a lesion that potentially has a communication to the pancreas duct, like an IPMN in an anxious patient, what are you telling the patient about the risk for pancreatitis? And is that a big concern for you with this technology?
Yeah, I think that's a good question, and it is a big concern, both for IPMN and for neuroendocrine tumors. So I tell them it's anywhere from a 3 to 10% risk, so it is fairly high. We give rectal indomethacin like in an ERCP, and if the lesion is, particularly for a neuroendocrine tumor, if it's close to the pancreatic duct, like within 3 millimeters, we would strongly consider a pancreatic duct stent. That may be a little tougher for IPMN because they're just communicating, but I think the risk is a little bit lower in those cases, but we just have to counsel them.
Yeah, maybe I can talk a little bit about the use of RFA for pancreatic cancer. So we know that in pancreatic cancer, local therapy by and large is not a great strategy, because we know that pancreatic cancer by and large is a systemic disease. But back 15 years ago, we did some a viral vector. So we created a gene therapy against pancreatic cancer, which we delivered by EUS delivery. And we were hoping that a local delivery would also create a systemic effect. But that didn't seem to pan out. But most recently, RFA, interestingly, shows signals of that possibility. Local therapy, RFA, now may well create what we call an abscopal effect, meaning we treat the primary tumor, but even metastatic lesions respond and shrink because of the recognition of the tumor antigen by the patient's immune system. So a lot of this work came from Nirav Thasani in the University of Texas in Houston. Others around the world, including in Thailand and Asia, have been also looking at this. So the preliminary clinical data suggested that patients who received local RFA had a longer survival irrespective of stages 1 through 4. All stages seem to have an increased survival. So that was a real interesting signal. So then Dr. Thasani's group then spent a number of years trying to look at the proof of principle in an animal model. So they looked at the mouse model. They implanted very aggressive pancreatic cancer tumor cells in the right and left flank of the animal. And then they just applied RFA to one of the tumors and watched to see what the response was histologically and immunologically on the treated side, but more importantly on the non-treated side. And both the treated and non-treated side responded.
Wow.
Immunologically, they saw tumor shrinkage, they saw upregulation of PD-L1, they saw collagen deposition, neovascularization, all the biologic signals that would indicate something is happening to the untreated side.
Yeah.
So then now we're looking at clinical trials now, looking at using this to leverage systemic treatment. So right now, for example, at Hoag, we're treating stages 1 through 4, and the patients are getting their standard therapy, whether it's gemabraxane or FOLFIRINOX. And then after a few courses of cycles of chemotherapy, then we're adding the RFA. We're doing ablation of the primary tumor. And if they have an obvious metastatic focus, say in the liver, we're also treating that. And we're treating every 4 weeks for 3+ sessions. And then after that, we're even looking at some of the immune checkpoint inhibitors.
That's what I was going to ask, if you're looking at the molecular markers.
We're looking at markers, and we're looking at checkpoint inhibitors such as pembrolizumab to see if then we can leverage the fact that PD-L1 is now being upregulated. So this is all new, exciting, emerging, but we're finding that adding RFA has really minimal risk if done well and carefully. We're very deliberate in terms of our dosing. If we see the impedance spike, even if it's at 20 seconds, we stop and we count that as a single ablation. We'll do 5 ablations per session, roughly. And we want to protect, if there's a lesion that's near the pancreatic duct, we want to protect that. Near the CBD, we want to protect it so we don't wind up causing pancreatitis or injuring the bile duct. But other than that, we find it fairly well tolerated, and we're hoping that we can prove histologically that something is happening in humans as well as in the mice. But most importantly, that we have a shot now at increasing patient survival.
I was going to say, why not try it, right? If pancreatic cancer has such dismal outcomes, any tool we have to improve outcomes, I think, is worth trying. And so I'm sure more to come on EUS guided RFA.